morning, everyone. My name is Bo Caden, and today I want to talk about reimagining user authentication for digital health services. As the introduction went, I'm a product designer, and I'm responsible for designing the user experience of digital products at MSK, Memorial Sloan Kettering Cancer Center. It's not a tech company, it's a hospital based in New York. So before I begin, I want to take a quick poll from the audience. Oops. Could you raise your hand if you have an experience using a patient portal, such as MyChart, or help someone else use a portal? All right, almost all of you. So health consumer experience is becoming digital. Today, 95% of all hospitals use EHR, electronic health record system, and it's granting individuals the ability to access lab results, communicate with their care team, and manage appointments at their fingertips. And we all know that COVID-19 has definitely accelerated this kind of shift. And telemedicine has become widely available. And without having to travel far away, wait 30 minutes at the hospital, see your doctor for 5 minutes, and then travel all the way back, for simple appointments, you can just take it at the convenience of your home. The dependencies on digital healthcare solutions will only continue to grow. So how can we make this transition successful? In order to answer this question, we must understand the two most important regulations that shape today's healthcare. First is HIPAA, that everyone knows, I'm sure. This law was enacted in 1996, and initially its purpose was to protect the individual's rights over the health information so that institutions do not share it without their consent. However, when HIPAA came to life, it was when the health information mostly existed on paper. And there had a lot of loopholes in the end as we started to transfer these things in the digital setting. So when it comes to EHR, it didn't have the full bandwidth to protect all the health information or regulate it in an appropriate manner. As a result, we saw health organizations taking an overly cautious approach to protecting PHI, even from the patients themselves. Up until a few years ago, and then maybe some of you also have the experience of this, but it was common to hear stories about patients having to pay a fee to get their records, or to carry around CDs of their scans, and then carry around to get second opinions from different doctors, because providers themselves were reluctant to sharing with other doctors because of HIPAA compliance. Things are starting to change. In 2016, the 21st Century Cures Act went into action to support the access, exchange, and use of electronic health information. What's interesting about this act is that it mandates the provider should avoid intentional information blocking, and that is making the providers make sure that users have access to their data without special effort and at no cost. So this has a lot of potential. Cures Act can shift the bureaucratic legacy in health privacy. It used to be health data is very important, therefore institutions who have the authority and the measures should protect it as much as possible. But now, Cures Act is putting a different perspective, saying that health data is very important. Therefore, you should have a seamless access to it and to control how you want to share with other people. This rule went into full effect in 2022 last year. And as you can see, EHR plays a key role over here. It has the potential to give easier, immediate access to your health records. But where are we today? The user experience design team at the Memorial Sloan Kettering Cancer Center gathered qualitative data from our end users through numerous thousands of feedback surveys, help desk inquiries about the common asks that we get, and also semi-structured interviews where we actually met the users from where they are. And based on these analyses, we learned that the biggest pain point of using the EHR was related to difficult authentication, citing their complex and outdated solutions. So let's take a closer look at the themes here. First is user friction. Research shows that password is still the most widely adopted authentication scheme for EHRs. The usability risks and the security risks are well known for this group. But moreover, even the consumer themselves are demanding for more passwordless authentication solutions, such as biometrics, that are easier to use and also more secure. Second is user frailty. This is a term used to describe a clinical condition characterized by physiological decline or increased vulnerability. Cancer patients who are in active treatment or older adults tend to have higher frailty scores. And it shapes their cognitive state, their motor abilities, and even lifestyle. Obviously, this affects people's authentication preferences. Imagine how frustrating it would be for someone with shaking hands, having to type a password that's 10 characters long, requires at least one uppercase letter, one special character that's not this and that. This is how you torture a user experience designer. Third is digital readiness. This term encompasses largely two things. First is the digital literacy, the individual's skill to use technology to retrieve information, interpret what they find, and also judge the quality of that information. The other part is the individual's access to internet, broadband, and ownership of personal devices to perform these tasks. Surprise, there are patients out there who don't have emails. Or more so, they have emails that their daughter created a long time ago, but they never really use it. So if the authentication scheme requires a certain level of digital readiness, those who are not equipped will be excluded from the system. Lastly, disjointed digital identities, the hardest part. The lack of interoperability across EHRs makes things even more difficult. Healthcare currently doesn't have a standardized patient identity management system, and as a result, users must go through a cumbersome registration process for each institution or organization that they interact with. And on top of that, they all have different policies on privacy and security, requiring different information from the users as well. So if the first step to accessing your health information, exercising your privacy rights, creating an account and logging in, that very simple step is already blocking users from exercising this right, EHRs will only be a privilege for some. And as of today in 2023, I think we're living in a very pivotal time for health privacy. There's a new regulation in place. Adoption of technology in healthcare is greater than ever, but there are also growing concerns about the digital divide. And it requires a collective effort across disciplines, including privacy engineering, health informatics, and policymakers to make this work out. So I wish to propose the following principles for us to think about. First, evangelize a business case for user-friendly authentication. In healthcare, there's a misconception that making things more difficult, like adding more locks to the door, makes things more safe and private. But health organizations should design their systems in a way that lets users provide a least amount of information to authenticate themselves. In order to do so, privacy and security experts must make strides to convince the stakeholders to deprecate outdated standards and invest in privacy-enhancing technologies. Second, apply a universal precaution approach. This is a principle that I learned from a colleague who works in the field of health literacy. And it assumes that all patients may have difficulty understanding health information and accessing health services. This approach stresses that it's not just marginalized groups who would benefit, but everyone benefits from ease of use. So therefore, rather than trying to seek for a one-size-fits-all solution, which I heard this term many times during this conference, EHR should consider that various situations and abilities can challenge the user's access, and we should aim to offer diverse authentication options to give greater control and flexibility to the users. And lastly, we still need a lot of work in policy. Institutions are seeking for guidance on the balance between access and protection of health information. In order to prevent intentional information blocking, there should be provisions to ensure the usability of EHRs, and we should provide systematic support to onboard new users who have various digital readiness. In this talk, there are a lot of complexities associated with consumer health privacy that I didn't talk about, such as privacy controls, proxy access, different types of PHI. But I thought that this only comes later once we mitigate the barrier to entry. Of course, these are also equally important parts. In today's talk, if there's one thing that I want to take away, is that you can also make a difference with some of these principles in mind, whether you directly or indirectly work in healthcare. Thank you so much.